In all my years as a pharmacist, I've watched people become increasingly worried and confused about calcium intake. So many people have been told that they've got to load up on calcium supplements in order to protect their bones. But as we're now learning, this well-intentioned advice could actually increase the risk of heart disease. It's frustrating to see people struggle with contradictory advice, especially when simple changes like adding vitamin K2 could make a world of difference.
Absolutely, Mary. After over 2 decades as a naturopathic doctor, I've seen firsthand how something as simple as taking calcium without the vitamin D and the vitamin K2 can cause more harm than good. And calcium has amazing potential for strengthening the bones, but without the right balance of other nutrients, then we can end up doing more harm than good by getting the calcium in the arteries instead of the bones. So helping people navigate these types of complexities has become a big part of my practice over the years.
So today we're going to dive into some of these calcium myths, looking at how calcium supplements can backfire on heart health, and exploring why vitamin D and K2 are critical for making sure that calcium actually benefits our bones instead of damaging our arteries.
And we have a special guest today, Dr. Ian Suzelis, DO, family practice doctor, who is my brother, as you've seen in other episodes. And he's going to give a little bit of that conventional background to round out this conversation, to help with this, to break down some research, help with his real world experience, to help give us a better picture of using the calcium and the other nutrients in our supplements to do more good than harm.
And if you've ever felt unsure, like I have, about calcium supplements or wondered what vitamin K2, vitamin D had to do with any of it, stick with us. We're here to break down the facts, go over the research, and use our combined years of expertise to help you understand this, which could be a complex topic. So stick with us, and here we go.
You're listening to Take On Healthcare with Ted Suzelis and Mary Sheehan. Have you ever wondered if you're getting enough calcium? Is getting enough calcium all it takes to prevent bone loss? Can a person take too much calcium? On this episode, we have a special guest for Dr. Ian Suzelis, who will help Mary and Ted take on the confusion around calcium supplements.
All right, the potential title of this, Dr. Ian Suzelis, the DO, is The Calcium Trap, Hidden Heart Risks and How Vitamin D and K Can Help. And the first segment is about calcium isn't always heart healthy. And I was thinking about back in my day as a little baby pharmacist working at Metro Health Medical Center and checking the bins in the morning where all the patient medications would go before they hit the nurse's station, and the nurses would give them out, and they would just be stuffed with calcium carbonate. But the messaging was always about people's bones, and we were very concerned about calcium with people's bones and making sure people get enough calcium. And that was it. That was the only thing that we needed. But yet you were just saying that there was something about calcium and lowering blood pressure. Is that part of why there was, in my opinion, like 20, 25 years ago, a big push to get everyone on calcium?
You know, and I don't think that was the actual push for it. Again, I think you're right. It was the bone health. That was just one of the side notes that you could say. I mean, there was some value to taking it to help to lower blood pressure some, but it wasn't the main point.
Okay. And it wasn't like every clinician was like, oh, this is how we're lowering blood pressure.
Correct.
Because those bins were also full of many different anti-blood pressure medications, things that worked the blood pressure. So it was, to me, like all about keeping people's bones healthy. We know you're tired of the same recycled health trends. That's why we dig deeper here at Take On Healthcare. But because we don't play into the clickbait game, we need you to help spread the word. A quick like, a comment, or hitting that subscribe button tells the algorithm this is content worth sharing. If you want more people to get real health insights, this is the best way to make it happen. Thanks for your support. We appreciate you. So that's all we needed. That's what the thinking was, that we needed the calcium for bone health. But recently we've seen that too much calcium can actually be bad for your overall cardiovascular system. Yes?
That is very true. Yeah. In the studies that they were looking at, they did some meta-analysis back in 21. And they were looking more at postmenopausal women in these different studies. And they found that there was like a 15% increased risk of cardiovascular disease with these people who were taking calcium supplements. And then they went further. There are some other studies that were even looking at people who had some renal disease or kidney disease, and they actually had an increased risk for cardiovascular disease or stroke. And so, I mean, there's definitely a correlation that they're trying to show between the elevated calcium, we're taking too much calcium, and also the heart disease or cardiovascular disease.
Back to the postmenopausal women, because that was the big push.
Definitely.
Like, okay, your estrogen is lower, your progesterone is lower, therefore you need to be careful of osteoporosis. So they
Correct.
were really pushing the calcium carbonate on these women. And so are you saying that the data was showing with these women the increased risk irrespective of any sort of hormone replacement therapy, exercise? Like when we talk meta-analysis, what did they factor in to that? Or is it just like, no, we factored in everything and this is causing the risk?
I don't think that they factored in everything when they were looking at meta-analysis. No, but they did make that correlation.
Okay. And that was there and that's in the data. So that's like very troubling. I always get troubled when we are doing something and we think it's the right thing. And then we go down the road and it was the exact wrong thing. And I get very, very troubled by that. Okay. So, today we're going to talk about then what is the role that calcium plays? And then synergy of calcium and other vitamins, which again, I always am amazed at how the dominant medical system thinks that there's just one thing and that one thing goes and does one good thing. Calcium. That's all. Just calcium going to do one thing for the bones. It's never that.
It's
in the real world. Right. It's just, that also makes me crazy about, the dominant system, and then how we can talk about just what you do need to do to balance, or what people can talk to their doctors about, since we don't give direct advice on a take on healthcare. All right, but to back up and to talk to the beginning, since people, again, what does calcium do in the body? Because I think most people think, well, I need it. I need to drink, well, it was milk, and then we were off milk, and then it was leafy greens, and then it was whatever it was. But I need my calcium so that my bones stay healthy so I don't get osteoporosis. That was the messaging, and the only messaging.
Yeah. So, I mean, as we're talking about the role of calcium in the body, I mean, it does have several different roles, and it just doesn't play into just the bones. When we look at the bones, we're looking at a store of calcium as well as helping to give structure to the bones, because we have this play between, we'll say, the thyroid and the parathyroid, and pulling, we'll say, calcium from the bones. The parathyroid will bring calcium from the bones into the bloodstream to perform different jobs, whereas the thyroid and calcitonin will help to put it back over into the bones.
Isn't that amazing?
It is.
That was like amazing. So our whole hormonal system knows that there's calcium in those bones. And do you need it or do you need it? And then it can take it and put it back.
Exactly.
I love that.
It is. It's wonderful. God created it.
Yeah, it is a genius. Amazing. So there's this system. And okay, when you say this system could pull it out, this system could pull it back, why? What else would it need? Why would it take it from the bones? That's the only place it's supposed to be.
It's used in different signaling throughout the body. I mean, whether it be for the nerves, it's used in the heart as far as for the electrical system and contractions. And also in the actual muscle itself, we use calcium in there to help that muscle contract. It's used in helping as far as our clotting system as well. So those are some of the main areas that we do see and utilize the calcium.
And the body is keeping track of all this.
Exactly.
Knowing what's needed when and where, and has a system to store it or pull it.
Mm-hmm.
Okay, I love that. But calcium, then, it doesn't act alone for anything, right?
No.
And even like in the beginning when we were talking about when I became then a community pharmacist and people were looking for calcium supplements. I would just try to tell them it's not just about that. If you're looking for something for their bones, which they always were, there's other things that people need for their bones insofar as calcium, right? So it doesn't work alone. It's not the only thing that's needed for healthy bones.
Correct.
So can we talk a little bit about that?
As far as some of the other minerals that you need, I mean, gosh, there are several other minerals. Phosphorus is another big one when we start to look at the bones and what it needs. But, today I think we're even more focusing on different nutrients that will help us as far as utilizing our calcium.
Right.
So, I mean, looking more at how do we absorb our calcium in the intestines? What helps us to absorb it? And that's where we come into the idea of looking at vitamin D. That's one of the biggest reasons that we look at that we need the vitamin D, and we suggest it for those people, especially the elderly who are telling to take the calcium along with making sure they take the vitamin D to help to get that in there to protect their bones.
So that does help with digestion.
It helps with absorption.
With absorption.
Absorption
That's
of the
another
calcium.
thing I was always worried about. If you're taking so much calcium, how do we know that it's actually just getting there? Because I think people forget. Well, I take it and it just magically gets where it has to go. But there is a system that happens in your digestive tract from your stomach.
Yeah.
And we just forget about that. Like it's just going to be fine. But it needs the vitamin D.
Yes, the vitamin D is what is necessary to absorb. If you have low vitamin D, you can end up having an issue where you don't absorb enough calcium. And our classic example of that is going to be children who have rickets. We don't hear about that anymore.
No.
As far as in the United States. But that was one of the big problems is that you didn't have the vitamin D, or they were vitamin D deficient, not absorbing the calcium, and then they would have this change in their bone structure.
Wow. And they were deficient because?
Well, it could be because of where we live. Because when we start to think about vitamin D and how we utilize it, it's not something that we find in our foods all the time, unless we're starting to fortify it. The majority of it we're having it converted through sunlight. So, I mean, the sunlight comes in and it converts our vitamin D.
Through your skin.
Exactly, through the skin.
A very interesting process. Right.
So that's what actually helps us as far as using it. So we live in an area here in northeastern Ohio where we have a lot of cloud cover. We are not getting as much of the UV light, and so we have more deficiency. And the further north you go, there's a lot of times, or in other, we'll say, states that have a lot of cloud cover, a lot of rain. Washington would be one. I know that the Netherlands are also an area where there's a lot of vitamin D deficiency. These areas, we have less UV light coming through. And that's what contributes. And when we're looking at the UV light too, I think that we're also seeing a filtering. We don't have as much of the type of UV light we need that's going to help out. And if I remember correctly, I think that it's the UVB is what we need to convert the vitamin D. And so, I think that that's one that we don't get as much of.
And that is why. Is it because of sunscreen? Because now the sun's our enemy.
Well, the sunscreen is a big one. I mean, a lot of people are, and you have to protect yourself from skin cancer.
Sure.
So I think that that's something that's very important. But at the same time, this is one of the reasons we need some supplementation.
Yes. That's just something that we kind of, again, we draw just a little bit of a straight line, or we're a little too simplistic when we're making in the dominant system, when we're making decisions. So really, an interesting messaging could have been, as we are deciding that everyone needs sunscreen, that we could also have been asking people to get their vitamin D levels checked. But I don't think we were getting them checked routinely until very recently. Or have you always checked them as a DO in your family practice? You've always checked people's levels, knowing we live in Ohio, knowing they're probably going to be deficient.
I would say for most of my practice, I have checked vitamin D levels. Wow. Although just recently there was a huge statement by the Endocrine Society saying that we don't need to check these levels. There were a couple different reasons. They felt that it was, I think, overall a strain financially on the health system.
I was going to ask you, are they expensive, these tests, the vitamin D tests?
I can't say that I actually know how much they cost, but they seem to feel that they were being ordered too much and that we were utilizing too much vitamin D as well. And they didn't recommend using as much vitamin D as we are using.
Interesting.
Yeah. And so there's a lot of pushback by a lot of, whether it be internal medicine, family physicians, rheumatologists, because, I mean, there's definite studies that show areas that we need the vitamin D.
I think you've hit on something that's so interesting that people don't understand, that goes to the system and the various influences of the system. So one group of people that are the endocrine people come up with a statement, but they didn't ask the cardiovascular people or the bone people or there's so many different factions.
Right. Yeah. And that actually, I mean, as far as when we start to look at it and we look at recommendations and what we follow, and this is kind of even a side note.
Who makes those decisions? Which faction of our dominating system gets to decide?
Yeah. A good example is when we start to talk about mammograms and recommendations for mammograms. And just as a side note. So you say, if you're talking to the College of Radiology, they're going to say, need a mammogram every year and continue it indefinitely.
Wow.
Okay, because they're radiologists. I mean, this is what they focus on. So yeah, that's what they want. If you talk to the U.S. Preventative Task Force, they're saying, get one every year from the time you're like 50 to 60. Before that, you can talk to your doctor about getting one. After that, get them every 2 years. And by 75, stop. They're looking at it from a cost perspective and saying, we want to stop this because, you know what, the person at 75, they're more likely to die from something else. So we're going to stop that and just not have it done after that or not recommend it. Versus if you look at, another faction, they're going to say something else. So all these different colleges give their opinion on something and they may not all match up, but they give their opinion.
They don't match up at a lot of times. And I think it's very confusing for people or they don't understand where some biases could be coming in with their doctor.
Right.
Where these things are coming, like just really big picture. I think that is a great example. So then I wonder, why do the endocrinologists not want vitamin D levels taken? What's the endocrine system? Because like we just said, that's the part of the system that helps regulate calcium in and out. I would think that they would kind of want that level. Or do they think it doesn't tell enough of the story to warrant it?
I think that, again, it comes to cost, but also there are a lot of people that are taking, vitamin D, or they're getting vitamin D and they feel the endocrine system, vitamin D is looked at as a hormone. And so that's what endocrine deals with.
Right.
But they also are saying, there's too much of this hormone going on and it affects different other functions in the body. We'll say some other areas where they may look at, we'll say even bone health. I mean, when you're looking at endocrinology, a lot of times whenever we have people who are osteoporotic, we're sending them to the endocrinologist to go ahead and take care of their bones. Because again, we talked about that play, the thyroid, parathyroid. So they're managing those different issues.
Okay. So you would think then that would put them in the expertise category when it comes to that. Yeah. And so they're just recommending not to have the levels taken.
Just don't check them as much. But again, I think that there is that.
But they believe in supplementation or no?
They do to a degree. There is, they don't recommend it as much as, say, somebody with family practice would. So say, again, like I said, rheumatology, we're looking at, there has been studies showing if you have a level between 60 to 80 as far as your vitamin D level, this is going to help out as far as with autoimmune disorders. It helps to regulate the immune system some.
Wow.
Yeah. So they weren't looking at that part of it. They're looking at it and saying, okay, if you have a level of 30, well, that's sufficient. We don't see that there's any, based on what they're dealing with. We're looking at from our perspective and saying, you really don't need much more than that. As long as you're getting that, or as long as you have that, you don't need to take any extra vitamin D.
Okay, I guess that makes sense. And to circle back, vitamin D is needed to get the calcium that you take from your stomach into the body.
Correct.
So what else is needed besides vitamin D, to get the calcium absorbed? What other nutrients?
Truthfully, the vitamin D is the main one that helps to absorb it.
Okay.
Which, this is something that I wanted to mention as well, is that we're hearing a lot now, and we're going to go into talking about vitamin K.
Yes.
And so vitamin K, I've heard several of my patients say, I heard you need to take vitamin K with vitamin D because it makes vitamin D more active, or that's what also helps you to absorb your calcium.
Yes, that's what I have heard too.
And of course, that's not the way that it works. They're both fat-soluble vitamins. So the vitamin D helps you to absorb it. The vitamin K helps you as far as placing it onto the bone. It kind of directs, we'll say, the calcium where to go.
So that's a great point. That's beyond. So now it's gone through the calcium has gone through the digestive system. It's hanging around in the blood, right? We don't want it just hanging around in the blood. It needs to go do something.
Yeah.
So that's where vitamin K comes in.
Vitamin K2. So there's a couple different forms. You have K1
That's very confusing.
and K2.
Yes.
K1, is one of the things I also wanted to kind of mention. We start to think about K1, the leafy green vegetables. That's where it helps out with our clotting. But also we start to think about it too when we start to talk about anticoagulants like Coumadin.
Yes.
And saying, okay, we got to limit our vitamin K1 so that we don't end up having some issues with, making our Coumadin less.
Exactly. Back when Coumadin was the only anticoagulant, and we had Coumadin clinics like we had at Metro, and we had to really monitor people's leafy green intake.
Right.
So K1, is that found in the leafy greens? Is K2 also, or K2 is a derivative, or?
K2 is actually manufactured more by like the bacteria, the microorganisms. We find this more in, we'll say, some meats. We find it more in fermented foods. Those are the areas where we find that more.
See, and I think people don't know that.
And this is another reason I know we talk about these good bacteria. We talk about going back to the biome.
All roads lead to the bacteria.
But getting these, you get these fermented foods, and we talk about eating the fermented foods. Well, this is another reason you're going to end up getting, again, the K2.
And the K2 is what's needed to help the little calcium that's bopping around in the blood get to where it needs to go.
It does help to direct it to the bones, yes.
Direct it to the bones.
Yes, that's one of the things, because there's several different forms. We'll say, now, there's several different types, we'll say, of the K2.
Oh my gosh, now there's types.
Yes, there's types, and we start to talk about, I think there's like 13 different types. The ones we focus on are going to be 4 and 7 as far as from what I've researched.
Okay.
But they both help out as far as the 4 and 7 are. They would both help out in getting the calcium to the bones. But also, this is one of the topics I think that Dr. Ted will even focus on more, is looking at how the MK7, which is what we call that vitamin K, helps out as far as the coronary arteries and the calcifications there. So
yes, that is a good topic. And yeah, I'm sure Ted and I will talk about it as well. But that was always a concern that I had. Like I mentioned that, okay, we were taking all this calcium. Is it being absorbed? If not, where's it going? Is it getting to where it needs to go? If not, and then I think there was something that came out about when we were studying atherosclerosis, there was a lot of calcium deposits in there. Yeah. And I remember thinking, well, shoot, should we have not been pushing all this calcium? How did it end up in there? We don't want it in there, because that becomes a very hard substance. Like people would think, okay, well, I have hardened arteries, or my arteries are filled with just cholesterol, but it wasn't what they were finding in there, right?
Yeah, the calcium is in there as well. I mean, this is part of...
And it couldn't be hanging out in there.
Yeah, it shouldn't be. I mean, this actually conveys increased risk for cardiovascular disease.
Of course.
It wasn't directly, I mean, it's not all...
There's no straight lines.
The calcium.
Right.
But yeah, that's definitely a correlation. And this is one of the tests that people can get nowadays to kind of also risk stratify. We talk about a coronary artery calcium score. And this is a CAT scan, which of course we have to think about radiation. But they do this CAT scan, and then they can actually look at the arteries surrounding the heart. And as they look at these arteries around the heart, they can see how much calcium is built up in there. And this is going to relate to the plaque. So
wow, I didn't know that we could do that.
Yeah. And they'll break it down into levels as far as the amount of calcium in there. And this tells us, what is your risk of having a heart attack or stroke? And we can give a percentage. We'll say, this is your increased risk based on how much calcium we see in those coronary arteries.
That's pretty amazing. So then that begs the question, if say I would get that done and they would see there's calcium, then what does one do? I mean, in the straight line thinking of the system, it's like, well, stop taking calcium. What would you say to that? Like, what does the clinician do then?
There's a couple different things. I mean, as far as whenever I'm looking at it, number one, when we talk about should I stop the calcium, I really do recommend to people, again, we're talking about where do you get your calcium? And whenever we're talking about the recommended dosage, which is recommended 1,000 to 1,200 milligrams, and we're talking about that for people who are 50 years or older. When we're talking about that, Do you get it from a pill? Do you get it from the foods that you eat? And what they've shown is that whenever we're talking about this risk of coronary artery, or we'll say coronary artery calcification or cardiovascular calcification, or even the risk of cardiovascular disease from calcium, they didn't see that from eating foods and the calcium that you get from your foods. I mean, food is,
food has its own wisdom. Right, has its own way of doing things. But if we supplement it, that's when they would see it.
That is whenever they saw that there was more of an issue.
Yeah.
So I talked first about, okay, when they recommend this, as far as these dosages, 1,000 to 1,200 milligrams in divided doses, you have to include the foods you're eating. So are you eating the cruciferous vegetables like broccoli and cauliflower? Because they're going to be good sources. Are you eating, the dark greens? They're going to be good sources of calcium.
Mm-hmm. How about dairy?
Dairy is a great source. I mean, getting that in yogurt, you can get it in different cheeses.
Which you'd get some K too, perhaps, right?
Yes, you would.
Okay.
Exactly.
And so the system is looking at that, because like when I talk to people, it's mostly they just assume that those recommended milligrams are coming from this pill bottle in this section of the pharmacy. They really aren't understanding that they should factor in their whole diet.
Correct. And I think that that's an important distinction that we need to talk to our patients about, so that we are making sure that they're getting the right forms of calcium. But also, I mean, when we're talking about these different foods to get these different nutrients, we're talking about healthy foods as well. I mean, these are beneficial foods for most people. So.
Right. Except then to go back to touch on that thing about the vitamin K, the leafy greens, if you're on Coumadin, then that would be.
Yeah.
Although there's not as many Coumadin people that we're used to. Now we have Eliquis.
Eliquis, Xarelto, all these novel anticoagulants where we don't have to worry about worry about the vitamin K.
Which is a really good thing about them, I think, that we don't have to worry about that, since those leafy greens are generally really good for people.
Exactly.
Yeah, so that is a good thing. Okay. So other roles of calcium in the heart, muscle contraction and heart health. So I don't think that's something that people really think about. When they think about heart health, they think about what you just talked about. How are my arteries that feed the blood and the oxygen to my heart? They don't think of contractility.
Yes. You know what? I got to admit, I think that usually you're not going to think about it unless you're going through biology class.
I love to think about it, but it's important. It is important that the calcium is available.
Yes. To
do those things, as are other things for the muscles. Muscles need calcium. Skeletal muscles, all muscles need calcium, right?
Yeah.
Yeah, to function, to do their thing. Okay. And then, of course, the calcium deposits, bad all around. And then other potential risks of high calcium intake. The kidney you mentioned.
Yeah.
So if the body has too much calcium, like we've taken all these supplements and we're not really thinking about anything else, and it's being absorbed and not getting where it needs to go, and there's too much of it, it goes through the kidneys for elimination.
Yes.
Okay. And then if there's too much there, what happens?
It can increase your risk for kidney stones. That's one of the things that it can do, especially if you're taking higher loads of calcium. Your body's going to be peeing it out. And yet that calcium being there can contribute to kidney stones. It's not that getting calcium, always makes kidney stones. Right. Because there's
lots of things make kidney stones, right?
Well, there's several different types, but the main one will say 80% of them are calcium oxalate. There we go. And we're talking about foods that have oxalic acid in them, or the higher oxalates, which binds to the calcium.
And then creates a problem for elimination. Yes, that would explain why there's kind of like some pushback with things like kale or other things that have high...
the oxalates, yes.
Yeah, the oxalates that are hard for people that, again, we're not thinking about.
Correct. And so, I mean, this is something, the calcium being available and having so much going through the urinary system then allows that to happen more.
And wouldn't that depend too, like... I always think about when a food comes on the scene and everyone's eating it, like say kale, and it's in smoothies, it's in everywhere. And then it's like, but wait, it has the oxalates that can cause kidney problems and other problems. Wouldn't that depend on the person too? Like how much they can...
It does. It depends on the person. I think one of the biggest things that I find in practice is it depends on hydration. People really need to make sure that they're drinking plenty of water. There are people that are predisposed to it as well. And so we have to watch them just from that perspective. But hydration is one of the bigger things I see with people creating kidney stones.
Okay, that makes sense. Back to hydration, right. And good clean water as well.
Yes.
I worry about the kind of water people are drinking as we push kale and water on people. I'm just wondering about with the water that it's been purified. All right. So what else do we need to cover? Oh, it feels like we're on segment 3. It's very, very much in the weeds though with the chemistry. We could go in the weeds with the chemistry. Let's see what else we could get in the weeds with. I found that the bone health and insulin sensitivity was very interesting.
I found it interesting too, and I'll leave that to Dr. Ted.
Oh, now I gotta wait. Okay, that is such a good one though, because everyone's worried about insulin sensitivity and everything else that's going on with metabolic disorder and obesity. So what other segment do you like that we could go into?
Let's see here.
I mean, the vitamin K is really in the weeds, which I'm happy to go in the weeds with the vitamin K. That's where I really got lost, that's not necessarily a bad thing.
Well, and a couple things that I also wanted to just touch on. And again, these are things that I see in practice, and I think that people need to pay attention to.
Yes, this is great. Let's talk about what you see in practice and what you think people need to pay attention to in general.
One of the things that I was looking at, and these are things that I hear from people coming into the office, calcium and magnesium. Making sure you take your calcium and magnesium together.
Thank you. Yes. And then I started to see, aside from calcium and vitamin D in a supplement, some of the supplements would start to have magnesium and people would ask for that. So what's going on there with the magnesium?
With the calcium and the magnesium, they are going to compete for binding sites when they're being absorbed. And so you have a ratio of calcium and magnesium that these supplements in particular are recommending so that you can actually absorb both of them.
Do we know what the ratio is? That seems very linear.
The ratio I do believe is, and Dr. Ted can correct me if I'm wrong, but I think it's like 2-to-1 calcium to magnesium.
Okay, I think that's when I looked at the bottles, I think that's what I was seeing. Like there'd be 1,000 milligrams of calcium and 500 milligrams of magnesium.
Right. I don't think that it's necessary that you take them together. And actually, I personally don't recommend that. And you'll have different opinions on that because they're going to be opinions. But I think that the calcium, you can definitely take that during the day, more with meals, and you're going to absorb it if that's what you need to take. Again, if you're not getting it in your foods.
Right. And the magnesium at night, isn't it very relaxing?
Yeah, it can actually help out as far as with sleep as well. But then you'll have it unopposed as far as whenever you're taking it versus, taking it with calcium.
So when they put it in the supplements, it wasn't really the best thing to do, but it was an easy thing to do together by putting them together.
Again, I think bottles. You'll have a different opinions on this. I think they're putting it into those ratios so that people are making sure to get both, but still trying to absorb them. But again, I think my personal opinion, I think it's easier and better. You can do that, take them separately.
And I love that the people are aware, that your patients are aware that magnesium is something that should be.
Right. And again, the reason I brought it up is because I think that there's also some misunderstanding because some of them think, I have to take the calcium with the magnesium and get them to be absorbed.
Well, yes. But that is perpetuated by the bottles on the shelves.
Exactly. Yeah.
And who's influencing the bottles on the shelves? Right. People don't think about that.
Yes.
Right. Okay. That is a really good point. What else do you see in practice?
Another thing that I wanted to bring up too is when we're talking about bone density, start to think about, we talked about the interaction with the thyroid and the parathyroid. People are on supplementation with thyroid medication, whether it's levothyroxine, whether it's Synthroid, whether it's Armour Thyroid.
A lot of people in Ohio, yes.
Yeah. And so when we see that, one of the reasons that we kind of watch it to make sure that we're in a normal range is because that can actually, and it was shown again with women more towards menopausal, but that if you have more hyperthyroid or if you're being over-controlled, it can actually decrease your bone density. And so it's something to pay attention to whenever you're just thinking about that as far as the bone density. Making sure you follow up to get your bone density scans.
How often do you recommend a scan?
Usually it's every 2 years. I mean, for women who are more at risk or if we're talking about postmenopausal women.
What kind of scan?
Well, they usually do the DEXA scan.
I figured. Okay.
But I've heard more recently, there's and I haven't got to research it completely, but over in Europe, I think they're using more ultrasound, and they're looking at how fragile the bone is versus just the bone density. Because I've seen people who have an extremely bad bone density. They have osteoporosis. They have falls. They never break a bone. I have seen other people who have, maybe mild osteopenia or just a little bit of bone loss, but they're having compression fractures in their back.
Fascinating. Something else is going on.
Exactly.
And they're onto that in Europe. I'll have to ask your other about that.
And I don't know. Have you ever heard of OsteoStrong?
Is it a product?
OsteoStrong is actually a place where you can go, and they've done some research as far as different exercises to help out with bone density. And so they actually have specific exercises. They also use pulsed electromagnetic frequencies to help out as stimulating bone growth.
I was wondering about that because you really do need to have some weight bearing on your bones as well.
Yes, the weight bearing is definitely what they focus on, and it's been shown that they can help out. But I've just heard recently that they had gotten one of these ultrasound machines to check and see as far as fragility, and that we may see this becoming more in line with what we do in the United States.
I think that's fascinating. And again, it goes to, it's just not one thing.
Exactly.
My bones are strong. It's kind of like I have good cardiovascular health, but are you flexible? Or I can walk 6 miles without getting winded, but you have strength. There's so many things that go in. And I think there's just this tendency, and partly it's the messaging, that it's just the one thing and you focus on the one thing. That's all you can ever focus on. And you kind of miss out by not relaxing into the possibility, or it's knowledge that there's lots of things that affect lots of things. Yes. Maybe that overwhelms people. It brings me peace. It might overwhelm other people. Okay. That is a good one, with people asking you about bone density and how often to take it, and the magnesium. What else clinically are you finding in this area?
Just things, again, you hear people talk about when we're talking about the vitamin D again.
Okay.
We're in a place we don't get a lot of this good UV light. Go to a tanning bed and get it.
Oh, dear.
Yeah, exactly. That's not the way to do it.
Okay.
And when we're looking at the tanning beds, they are more harmful. And whenever you're getting that, we were talking about the UV light, you needed the UVB to convert the vitamin D. They actually use UVA. And so you're not getting any benefit to actually helping out with the vitamin D there.
Aren't there some other things people are doing, like these or the red saunas, or something people are doing with light at home?
I know there's all kinds of different treatments with, light therapy. And
what we're doing with light.
Yeah.
Maybe they're not doing that for bones. They're doing it for something else.
They actually, depending on the different colors you use, they actually have been shown to penetrate the skin at different levels, whether it's to stimulate healing or to actually help to fight off microorganisms like oncogen. There's so many different things.
That, which also could be confusing for people. But the bottom line is, if I'm hearing you correctly, in your opinion, there's really no therapeutic benefit from the tanning bed.
Correct. And that's one of the things I just wanted to make sure was out there.
Right. That is a myth perpetuated by big tanning.
That is it, exactly. Or, people who say, light equals vitamin D, and I'm going to justify what I'm doing. A little cognitive dissonance, maybe.
Totally. And most people don't know. And even I don't even like the frequencies of light, and it's just a whole science in and of itself, right?
Yes.
Frequencies of light and what it does on the skin and the chemical changes that happen, and then what happens under there. That is a really great point. I'm glad you got that out there, that you got out the magnesium point and the tanning bed point. Any other?
I would also say one of the things that we need to talk about, again, when we're coming back to that vitamin D and vitamin K, they are fat soluble. When we start to look at fat soluble vitamins.
Meaning it's yours? Okay, so to explain that to people. So vitamins, say you take a B supplement or vitamin Bs, for example. Yeah. You take them and the body doesn't need them. You just pee them out because they're water soluble. Fat soluble means it's not so easy for the body to eliminate if there's too much.
Correct. And that's one of the things, when we're looking at it, they're not going to go through your urinary system and leave the body. Right. Body doesn't get rid of these vitamins that way. Okay. But also for absorption, it's important to know that they're fat soluble. When we're taking in fat soluble vitamins, we need to stimulate that digestion to absorb them. We need to, whether it's with the different foods we're eating, which I think, if you have a little bit of fat with your meal, if you're We talked about the vitamin K with some of the different meats or with some of the dairy. Those are going to have some fat
so
in those.
it's like nature knew.
Exactly.
We're going to put this with this because they like each other.
And
It's
they're
going to be better for the
absorb.
people or the animals that are eating it, whatever.
And- Or whenever people are taking supplements. If you say, I'm going to take my vitamin K supplement or my vitamin D supplement, if you want to make sure you're absorbing them, those are ones that you're going to want to take with a meal with a little bit of fat in them.
Good advice.
Because again, we're stimulating digestion. You have to stimulate digestion.
Yeah.
And your body says, what am I taking in? And then it starts to gear towards that.
I love that. That is a really good point that goes into like the other myths about I shouldn't be eating fat. It's a great example of like where fat it can be your friend.
Exactly.
Fat and food can be your friend and help get these other good things in your body. That's a very good point. Any other clinical thing you wanted to cover?
I think those were some of the big ones that I just wanted to make sure that I got out there. Things that, I see in practice that wanted to help to take away some of these myths or help people to understand it a little bit more.
I love that. And those are really good for me, like to remember as I practice pharmacy, behind the counter when people are asking about this, or say sometimes the doctors will write a prescription for calcium citrate, and it's a good little conversation to have with people. I always like to do that, like just to see why they're taking it and what kind of other conversation they could have with their doctor, depending on if they have the bandwidth for it. So I think that's good for all of us to think about. And I want to get one of those fancy things for my bones to see how they're doing in there. They seem good, but I don't know. I want some, what it is, trust but verify, right? Like I think I'm doing all the right things, but I think that's a good thing to think about. And the heart thing that you mentioned about being able to see.
Yeah, the coronary artery calcium score.
Fascinating.
Yes.
And is that routine?
It's something that you would actually ask your doctor about, or if they feel that it's something that would fit you to risk stratify. A lot of times I'm looking at patients, we'll say if they have high cholesterol, which is another talk.
Yeah.
But they are resistant to taking a statin if I say that they need it, or we're looking to say, do you truly need to do anything with this? And so that's one of the things that I can look at to help to risk stratify and say,
that's brilliant.
I don't think that I need to do this right now. I don't need to put you on a medication for this right now.
Oh, I love that. That's such a big picture sentence right there. Dr. Ian Suzelis, DO, your family medicine, right?
Yep,
family medicine practitioner. Thank you very much for joining us on Take on Healthcare and lending your expertise and wisdom. We appreciate you.
Well, thank you so much, Mary, for having me.
So thank you for bearing with us as we have this little bit of a transition in our episode, trying to get Dr. Ian Suzelis in and get all the good information that he's provided. He had a little bit limited time, so we got him first. I want to cover a couple of little pieces to work into a couple of extra interesting segments. So we're talking about calcium and vitamin D and vitamin K. Definitely the K2 is that piece that's definitely a lot less known for most people.
Oh, absolutely. That was I think I might have learned that at one point, but didn't remember it at all. You know where I had to learn it, obviously, is when Coumadin was the only anticoagulant on the market.
Yeah.
And I had to understand the interaction between vitamin K and Coumadin. Yeah. And then I did learn about K1 and K2. So it's been a long time since that's hit my brain.
Mm-hmm. Yeah. So this vitamin K2 is such an interesting molecule, and this whole thing with the heart disease and the bone health, obviously we're calling this episode the calcium trap because we have this dichotomy between, do we work on keeping the bone strong, or do we work on keeping the heart strong and not, have heart attacks?
Yes.
Where's that interaction?
Yes. Because in the dominant system, one must choose a system.
Right.
And not in your system. Not in the naturopathic physician's way of looking at things. There is not as much polarity.
Correct.
Which is a myth. This polarity is a myth, right?
Definitely.
Okay.
Definitely. Yeah. So this vitamin K sort of helps bridge that gap.
Well, I love that.
Yeah. Because vitamin K2.
K2.
Yes.
Which is really a vitamin, unlike vitamin D, which is a hormone. Vitamin K2 really is a vitamin.
Yeah,
but it seems to like act so differently than your
does. It does act like it does. You know, there are some ways where it acts like a hormone too, because in order to where it's all working with all this is a compound called osteocalcin. So in the bones, osteocalcin binds to calcium to help strengthen the bones.
Okay, that's its job.
Yes, but it also works in the arteries. Well, you have the osteocalcin, and then another protein, matrix GLA protein, works. It's also activated with vitamin K2, and it binds the excess calcium in the bloodstream to help so that it doesn't calcify the artery.
I think that's amazing.
So we have these two different
those things are in there. Two different proteins,
right?
Two different places, both responding to K2.
Right, because like 99% of our calcium is stored in the bones, the rest is in the tissues and the arteries.
Doing its very important things.
Right. And so, yeah, vitamin K2 helps to orchestrate where the calcium's going.
Well, that's why probably you think of it more than just a vitamin.
Right.
It's that orchestration.
Right. Right, because it does activate those proteins too. So
to do
you
what
think of that more of like a hormonal effect.
Exactly. Yeah, I do. Yeah.
Yeah. And so there's definitely a lot of, it's one of those things where there's research and it's hard to find good research about this. They're still putting the pieces together because definitely we're seeing research where with people that have higher levels of vitamin K2 are less likely to have calcification of the arteries and less likely to have coronary artery disease. In fact, one study, Rotterdam study, it was looking at cardiovascular mortality, and it showed like a 50% reduction in cardiovascular risk with the highest levels of vitamin K2.
And this intake, this K2 intake, was it supplementation or was it people's diets? They surveyed the diet.
This was looking more dietary.
Wow. And vitamin, again, to remind me and everyone, vitamin K2 is found.
So there's a couple of different sources, definitely manufactured in fermentation. Like the highest level of K2 is found in natto. So that's
a
product.
That I've never heard of that.
Yeah.
Where have I been?
Well, you haven't been in Japan.
Okay, thank you. Okay, so that is just something they find in Japan.
Mostly, I mean it's
they
here, but
pretty good cardiovascular health overall as a people.
Yeah,
this could be part of it.
Yeah, but also it's found in dairy products, and especially more grass-fed dairy products. We see a lot higher levels of the K2.
Yeah, I love that grass-fed.
And so when you and Dr. Ian were talking about the studies looking at calcium coming from food sources versus supplement sources.
Yeah.
A big part of the calcium coming from the food sources is coming from the dairy.
That had the K2.
That already had the K2.
Amazing. Okay.
Yeah, that's the thing. We look at this, it's never in a vacuum.
Thank you.
I say that all the time. There's never, because there's a lot of different hypotheses about why the elemental calcium in the supplement would be different. I just think it has to do with, it has some of these cofactors that you need to utilize the calcium properly.
Love that. Okay.
And so going beyond bone health and cardiovascular health, there's also a really interesting other piece to this, and actually still goes along with the bone health too. But the vitamin K2 activates this osteocalcin that we talked about, which is important for bone development and strength, but it also works for insulin, to regulate insulin, to improve insulin function.
Which is amazing and something everyone, we are thinking about that now.
Definitely.
When we're thinking about metabolic syndrome and obesity, and this is a big focus now.
Right.
So you're saying that somehow vitamin K, with its role with calcium, and the bones has to do with insulin resistance.
Right.
Fascinating.
Right. And they've developed this bone pancreas loop that they're talking about now where with looking at the
The bones
interaction.
and the pancreas are now talking to each other. Oh my God.
Yes. Talking about that osteocalcin, which is originally thought of as a bone protein.
Right. Like as you just explained.
Right. But it also works on helping to regulate insulin too.
Amazing.
Right. And in my research with this, and I don't have it right here, but I did see this osteocalcin does stimulate with the help of vitamin K, because vitamin
K2.
K2 activates the osteocalcin.
Okay.
And one of the roles of it is stimulating the glucagon-like protein 1, the GLP-1, so Ozempic and all that kind of stuff.
Yeah.
So it works all in there together.
Amazing.
Yeah, crazy.
And that is, and this is recent information, yes?
I don't know how recent, but obviously the recent thing is having drugs to target the GLP-1 receptor.
Of course. And as you research, you always find out the other good stuff.
Right. Right.
Love that. Little side effect of the research, as it were.
Right. And so, I mean, with that, you can't, like we've talked about before when we were talking about Ozempic and these drugs, they're working not just on a physiological level. They're ramping up that GLP-1 a lot higher than what the body would normally have. That's why people don't have hunger at all when they're on them.
Yeah.
And they're so they're hyperdosing it, not to help with a deficiency, but going more as a therapeutic. And so I would doubt that we could do the vitamin K and this osteocalcin in a way that we can mimic.
No, we can never do it like to that extreme. But what is the take home with that then?
Well, it's just another piece to regulate the body's normal functions.
Yeah, that you have to be aware of.
Right. Yeah, and so.
So, and again, just help manage insulin resistance. So if there's insulin resistance, that is very bad for your metabolism, as that would promote fat storage.
Correct.
The osteocalcin helps the insulin get where it needs to be, which is in the cells or is it not that direct?
It's not that direct.
Right.
It stimulates, for one, it stimulates a hormone called adiponectin that boosts insulin sensitivity.
And insulin sensitivity is good.
Right.
We want our body
because
to
we
be
talk about
sensitive.
insulin resistance, and we've talked about this many times.
Right. We cannot talk about it enough,
Right.
in my opinion.
So we might as well go over again and talk about my wonderful little analogy with the Amazon delivery person.
Yes, please do, because it bears repeating.
Right. So we have, our house is a cell. These hormones are messengers. So you're sitting on the couch watching whatever TV show you want to watch, and the hormone, the insulin, is the Amazon delivery driver.
Mm-hmm.
And he comes up and rings the doorbell because there's excess sugar that you need to take and bring in the cell and have dinner.
Right. To promote energy and do all the things you want to do.
Be better off to say the DoorDash or whatever, but no care. So yeah, they ring the doorbell, and you open the doorbell, take your package, the sugar, let some sugar in, and close the door. And then sometime later, when there's excess sugar again, they'll come back up, ring the doorbell, let more in.
Mm-hmm.
But if you have kids down the street playing ding and dash, where they'll ring the doorbell and then run away, and you keep opening the door and there's nobody there, eventually you're going to stop opening up the door every single time it rings. You'll wait a couple of times, maybe 2, 3, 4 rings before you say, okay, I'm getting up off the couch and I'm going to the door to get my sugar. And so that's insulin resistance, because your body is, and it's I guess another analogy would be like the boy that cried wolf.
Yeah.
It's where there's way too much. Your cells can't keep taking that sugar in. Right. So they're like, okay, we have enough. We need to wait a little bit longer. So your body, though, you have this push and pull where your pancreas is saying, but our sugar levels are really high.
Yeah.
We need to get this sugar in the cells so we can lower the sugar levels. So you keep producing more insulin, but the cells are hesitant. They're like, we can't handle this. We have too much already.
Right.
And so that's that push and pull.
Mm-hmm.
And so with that improved insulin resistance, it also has to happen with the blood sugar levels reducing too.
Yeah.
Because you can't reduce that insulin resistance but still have the same high sugar where you're pulling all the sugar into the cells.
Right.
And so that was something that was found with all of this research too, is that the K2 would stimulate the osteocalcin, which would then, help produce the adiponectin to boost insulin sensitivity, but they were seeing the higher levels of adiponectin, but not the improved insulin sensitivity necessarily, because they were doing a study just in a bubble. They weren't working on
in a vacuum,
getting the sugar levels down, because our bodies are so smart. We can't just, we can have different triggers, and it has, multiple fail safes to make sure that everything works properly.
Right.
With that, it just makes a really interesting piece to all these different factors. They obviously all go together, because the insulin resistance is a big factor for heart disease too.
Yes. Circling back to heart disease, which again, we tend to forget.
Right.
How widespread the damage of insulin resistance, all this jacking up of the insulin, the damage it does to your brain, to your heart. It's like it's everywhere. It's everything.
Yeah. And the other piece of that, which is really why when we're talking about the heart and the bones, I wanted to bring in this insulin resistance piece, is because if we don't take care of the insulin resistance, no matter what you do, you're not going to build your bone density. You can throw all the calcium and the vitamin D and the vitamin K2 and and the bisphosphonates and everything else in.
Neat.
But if you don't take care of the insulin resistance, you're banging your head against the wall. You can't get those bones to build up.
Oh my gosh, that's a great takeaway.
Yeah.
And because, again, I don't think we as a people or individually can sidestep this issue at all. And I think we're trying real hard to sidestep this issue. And we really cannot.
Right.
Of insulin resistance, metabolic disorder.
Yeah. So
then how do we find this balance? How do we find the balance between the calcium that we were talking about, the vitamin K2, the D? How do we do that? How do we balance it?
Yeah. So the way I do it in my practice.
Yes.
So I typically, if we're just looking at the osteoporosis, the bone density part.
Okay.
So I have a formula that has calcium, magnesium, some vitamin D, some vitamin K, boron, silica, all of these different nutrients that are needed for bone strength.
Okay.
And I also have my multivitamin that has extra vitamin D and vitamin K to all of that to work together to give us decent doses of all of these nutrients to help together to make sure that we can improve that bone density.
And you would choose that only if someone had a low bone density score?
No, it can be just
Memories
too.
Sure.
Right.
Okay.
Right. Because
again, you're looking at the whole patient.
Right.
It's not like there's a little lab result that's come across your desk.
Right.
And you're making recommendations based on that. You're not.
No.
Treating the whole patient.
Exactly.
Okay.
And so with that, it definitely is, we have to make sure that we have the right doses of all of these different nutrients. And your conversation earlier about the calcium carbonate, because we do get a lot of it in with our foods. Yeah, the calcium. So that's the piece that I don't worry about as much.
Calcium.
The calcium. So I use calcium carbonate in my bone formula because
but again, not a lot.
no. So, I mean, in a 4 capsule dose for the day, it has 1,000 milligrams of calcium.
Oh, okay. So that's like right on par with
Right.
what's
Because we're not worried so much about just getting that calcium in because you're cramming it in with your food and everything else.
right.
But then we're also getting in the magnesium with it. And your conversation with Dr. Ian also about those together, there's a ratio between calcium and magnesium. And I'm not, I mean, I really
found in food a lot of magnesium. I feel like over time, what I've read or understood is we're not getting the magnesium that we used to.
Correct. The research that that I've seen, and of course, this is going back 25 years ago to medical school, was that the food that we eat has a third of the magnesium that it did 100 years ago. So we know it's only gotten worse since then.
Due to soil depletion.
Right, because farmers farm the same land over and over again.
Which is probably not how it should have been done.
Right, but
this is where we are.
The problem is that magnesium isn't needed to make the plants grow well, make them grow quicker or anything else.
So there's no motivation.
There's no motivation because it's not going, it would be an extra cost, but they're not going to get an extra benefit.
Got it.
So therefore, our magnesium in our food is greatly depleted.
How the farming system affects the healthcare system.
Exactly. Yeah. So we need to so most people are deficient in magnesium to some degree.
That's what I thought.
And so we need to make sure we get that. We need to make sure that we get the vitamin D because we don't want to get skin cancer. So we are keeping our skin covered. And plus around here, we couldn't get it hardly if we wanted to.
Couldn't get skin cancer if we wanted to.
Well, back in the day when you would use baby oil and stuff. So you could
stop it. I did that. It's 1970 something.
That's
80.
right.
Yeah.
Yeah. And then all of these other nutrients. So they work together. And
of course.
Yeah. So that's, and that's where I didn't understand exactly all the pieces when those first calcium studies came out, but looking at it, I knew that these were studies just looking at calcium and you weren't looking at all of the other actors involved.
Yes.
And so it's been then a process over time, understanding how they fit together. And especially with that vitamin K2, that has a real orchestrator there, the hair problem, because it will dictate whether the calcium goes into the bones or into the arteries.
Which I think is just a great takeaway, for people to be very careful when the media or some influencer or somebody is touting something and they're not really factoring in, well, first of all, you and all of your chemistry, but all of the other players. I think that's always such a good thing I like about this show is it makes people think that it's just never ever going to be just one thing. There's many things.
Right.
Like my new best friend, vitamin K2. Yes.
And I found that I didn't know the source up until we were studying for this episode. I didn't really understand the sources of it too, that you get it from a lot of the fermented foods and the dairy products, grass-fed dairy especially.
Right. And the fermented foods, I think, are really, people do talk about that for gut health. And you got this added benefit with the vitamin
and it's
K2.
And it's still somewhat low doses. It's not like you can beef up on getting your K2 to do everything with the foods. It's one of those factors that when you deplete it over time, you can't just build it up automatically with your food source. That's why we have to supplement.
You would have to supplement.
Right.
And do you recommend getting these levels taken? I've never heard of a vitamin K level being taken.
Definitely not a vitamin K2. I don't know.
How do you decide? How do you know if they're depleted? It's a big picture thing.
Right.
It's not just
I don't worry about that. I didn't worry about making sure we are supplementing enough and assuming that if somebody does have the osteoporosis and everything that they're deficient, we need to build it up.
Makes perfect sense.
And so, of course, that also goes, since a lot of the K2 comes from the fatty dairy, that we've been told since the 70s that we need to get rid of.
Right.
So we have another factor there when we're talking about obesity and diabetes, along with the low-fat diets, high-carbohydrate diets that can help. Another piece of that is you're not getting the same amount of vitamin K2 to regulate that insulin sensitivity either.
So another thing wrong with that advice,
Correct.
like too many carbs can confuse the insulin system.
Yes.
And then you're omitting something that gives you something very important for your overall metabolic health to decrease insulin resistance in the form of the vitamin K2. Oh, another place we went awry.
Yeah, and so then the last piece of pulling that all together does come down to, with the K2 especially, are you on a blood thinner? And if you are, ask your doctor.
You mean Coumadin?
Well,
not or all of them?
No. I'm saying to the regular consumer, you should just ask your doctor anyhow.
Agreed. Yes, of course.
He says yes. So the Xarelto and what's the other big one?
I know. Why am I drawing a blank? I give it out every day. Eliquis.
Yeah. So those aren't vitamin K dependent and are safe, but the other ones, the Coumadin and warfarin, can come in other names too. So we we don't want to give a big blanket statement. Just talk to your doctor.
Right. Yes.
It's better to be safe than sorry.
Correct.
And it doesn't take a ton of, I think it's like a milligram of vitamin K can throw off that balance with the Coumadin or warfarin. So when we're looking at, typically we're talking about microgram doses of it anyhow.
Right, but still.
So people that are really need it very well could supplement, and may have to increase their dose of the Coumadin.
Oh dear. Yeah.
A little bit.
That's why.
Or talk to their doctor about switching to one of the other non-vitamin K dependent medications to thin their blood.
Well said. Well, I learned a lot from this episode, as well as having a good reminder about how there are no straight lines in nature, and about how it's always more than one thing that has to do with whatever it is we're talking about, your health, whether it's your bones, your heart, your metabolism. Thank you so much, Ted, for doing all of the research. And thanks again to Dr. Ian Suzelis. It's always a pleasure to have the guest that is your brother.
Right.
And we really appreciate you listening.
And thank you, everybody, for listening to this and watching this episode, and we'll see you in the next episode.
Take on Healthcare was created and is hosted by Ted Suzelis and Mary Sheehan. The information contained in this podcast is provided for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider. Carefully read all labels and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Mary Sheehan and Ted Suzelis, disclaim responsibility for any possible adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations for warranties about guest qualifications or credibility.